children do have ankle problems just like adults do. And it's a big advantage working in foot and ankle surgery, treating children and adults, which is what I do on a regular basis, because there are certain ankle problems in children which don't occur in adults, and then children sometimes get their own version of the same problems that adults have. There isn't a big overlap, though. They tend to be one or the other. And ankle problems in children are not all that common. I mean, musculoskeletal problems in children aren't that common anyway. But there has been an increase in ankle problems in children as the sports which we allow them to do and perhaps encourage them to do have become more and more intense over the last few decades. I saw this first when I did my fellowship in Toronto quite a while ago now. If a young boy showed some talent in ice hockey, then the pressure on this young chap to do lots and lots of training was pretty intense. And I used to do some clinic consultations where there were 4 of us in the room. There was me, and then opposite me, a young boy. And there was also 2 parents and a coach. And the coach was sat next to the boy, not the parents. And the parents were sat at the back and had to keep quiet while the coach grilled me on what might be wrong with this young boy's ankle or knee or whatever, and what I was going to do about it. So the sports may create some problems, but as long as the training is good and sport is good, support is good and the exercises before sports are good, then that shouldn't be too much of a problem. But there are some design problems, is the best way of putting it, which people can have in their ankle, which become apparent during childhood. And they tend to come in 3 different types. One of them is that some people have rather flat feet. And most of the time when the arch is shallow, the arch is flat, it's just a range of normal. Some people have deep arches, some people have shallow arches. But if you have one or the other, then they can cause mechanical problems and aching and pain. Even in childhood. So the mechanical side of things is something one always has a look at. And sometimes these abnormal shapes can indicate a problem with the structure of the bones internally. And so that is the other 2 types of problems which we see. Occasionally there is an abnormal join between 2 of the bones in the foot, and that's called a coalition. They're not very, very common, but I wouldn't say they're rare either. It's hard for me to be able to judge that in my clinic, because of course those patients tend to be referred to me, so I see lots of them. But a coalition is where 2 of the bones just below the ankle have a join which shouldn't be there, and sometimes that join is made of fibers and sometimes it's solid bone. It's not because the bones have joined up, it's because they fail to separate fully during development before birth. And some people undoubtedly go through their whole lives with one of these coalitions and never have symptoms and have a normal functioning foot. But symptoms can occur, and most commonly in teenage years. And we think that the reason the pain is usually pain, which starts to develop during teenage years, is for 2 reasons. One is that person, that young person, is starting to do more intense sports and is bigger, heavier and stronger, and putting more strain on this abnormal joint, which does not allow 2 of the bones just below the ankle to pivot in the way they should. And the other possible reason, and it's probably a combination of both, actually. The other reason is that the join, as the skeleton matures and goes towards maturity, the join becomes more solid. So the flexibility in that join, that coalition, reduces, and pain starts to become an issue. So a typical time is between 10 and 16 years of age. So there are particular patterns of pain which the young person might complain of. And then on examination, usually it's pretty straightforward. From recognizing the pattern of pain and the features in the movements of the joints, that's what's happening, and then scans will confirm it. And there are treatments which one can successfully apply. It's quite common for those people to come and see me, having seen quite a few people before, because the symptoms can be very similar to just some foot strain or an ankle sprain which hasn't got better. So there's always a huge sense of relief when I managed to make that diagnosis and explain that there was something behind it. I mean, some young people even start to worried that people aren't believing them, and that's an awful situation for them to be in. So for somebody who specializes in that field to be able to show them on a plastic model and show them on their scans exactly what it is, and I can say to the parents, just in case it crossed your mind, your son, your daughter is really experiencing that. Even just that is very helpful. So coalitions. And then the final thing is, some people are born with extra bones in their foot. They tend to be quite small. We are all supposed to have certain small bones in our foot, like under the ball of the big toe. But some people are born with extra bones which shouldn't be there. And again, many of those people undoubtedly live the whole of their lives without any problems, maybe with a small bump on the side of their foot or something like that, which rubs on their shoes. But a lot of these bones are embedded within tendons, often just before the tendon attaches to a major bone. And so what is really happening is the tendon is pulling on this extra bone, which is often the size of a bean or a pea or something like that. And the attachment of that extra bone to the main bone is being constantly pulled on, and that join is sometimes not as strong as a normal tendon. So pain begins, and that pain often begins in childhood or in the young teens. So these are the diagnoses which I've always got at the back of my mind, and the majority of times when meeting somebody with pain in the ankle, in the foot, a young person, a teenager, it's a mechanical thing. Maybe they have to modify their sportswear, do some better training. But every so often I spot something, and there is a design problem, if you like, in their foot which needs to be addressed. Yes, so ankle pain beginning in a young person who hasn't had an injury is an interesting one. The first thing to do is to go into the story in a little more detail to be absolutely sure there hasn't been an injury. It's so easy to sustain an injury on the sports field and forget about it and not realize or carry on with the match, and then it's only the next day that it's a bit sore. So I never take that at completely face value. I always go into that in a little bit more detail. Has there been an injury? And there may not have been a specific injury, but it may be more of a repetitive thing. So you have to ask in detail about whether somebody has recently started training for a more intense sport, for a marathon or a run of some sort, or gone up in the team, and now they're playing sports with people who are older than them, bigger than them. All those things are really important. So it may still be an injury of some sort. If it isn't, then you then have to start thinking about the shape of the foot. Is there a mechanical problem there? Is there a shallow arch which requires support? Is there a deep arch which is throwing the foot over sideways and they need insoles to tip the foot the other way? All those mechanical things are very important. And then I start realizing that my main role here is going to be to exclude any structural problem within the foot, an abnormal bone that they might have been born with, or an abnormal joint between the joints they might have been born with. I exclude those, analyze the mechanical problem, and my role then is a facilitating one to help them meet the person who's going to treat them, who may be a physiotherapist, maybe a podiatrist who can design some tailor-made insoles to correct the mechanics, and often a combination of both. And then often there'll be a final appointment to see me to make sure that they're getting better and that that approach to treatment has been successful. And then the ankle can start hurting because of a structural problem, and then scans can be helpful in working out exactly what that is. And then there are some problems that can occur in the youngster's ankle which I treat regularly in adults. So the cartilage in the ankle joint has a lot of work to do. There's a lot of strain on it. It's easily damaged if the ankle is sprained, and if the cartilage starts separating from the bone in one corner of the ankle or the other, that can create pain. That's called an osteochondral lesion or osteochondral damage, and that can happen after injuries. But occasionally I will see it in youngsters without any injury at all. And I've looked at this in the literature many times. I've talked to colleagues who also happen to have specialization in the foot and the ankle in children and in adults. So we all see that problem in adults, and we all occasionally see it in children. And nobody has really explained why that can happen sometimes even without an injury. But occasionally it does. Fortunately, the cartilage in youngsters heals much better than it does in adults. And that certainly is the case up until late teens, early 20s. So you're much less likely to need to do any surgery. If surgery is required, then it's usually keyhole, arthroscopic surgery. So I would say, even though I see lots and lots of youngsters with ankle problems, I probably see that problem once a year, maybe once every 2 years. But it's a very important diagnosis to make, and then to follow to make sure those symptoms settle. So cartilage damage in the youngster's ankle occurs just like it does in adults sometimes. So weak ankles in children is a symptom which I'm occasionally presented with, probably less than you would think, because this is very often a mechanical problem to do with the posture of the foot, which makes it difficult for the foot to be stable, and so it's easy to sprain the ankle. And particularly in youngsters and in adults as well, I would say, but particularly in youngsters, the solution to this is very often physiotherapy, maybe supplemented by custom-made insoles. And that is often recognized by the patient's general practitioner. And if that person comes to see a physiotherapist, especially if they have experience in that sort of area, they will recognize the problem, treat it successfully, and they never meet me. And they never need to see an orthopedic foot and ankle surgeon. But sometimes they do. And the sequence of checks that you go through, you look at the foot posture and also check for hypermobility. So hypermobility is a condition where the ligaments which strap one bone to the other are more elastic than they should be. Youngsters have, young people have more elastic ligaments, stretchy ligaments than adults anyway. We all tighten up as we get a little older. But some people have abnormally stretchy ligaments, sometimes to such a degree that they have a true syndrome, which can even affect their health in a general way, in a serious way. So all those diagnoses one would like to, what you need to spot, I need to spot, but they're all unusual. Most of the time, if there is weak ankles, the first thing is, well, what do you mean by you have weak ankles? And sometimes that's because they ache and they're sore when they're doing sport and walking long distances. And that's a very common symptom in hypermobility, because if the ligaments that strap your bones together are extra stretchy, then the muscles with the tendons on the end of the muscles pulling on the bones, which is an active physical thing, that has to happen much more energetically to compensate for the stretchy ligaments, to keep all the bones and the muscles straight. That requires work. That's why people with hypermobility develop very tired legs when they're walking, and children do. And that's an important diagnosis to make, because this young person, it can often be very young, sort of a toddler, not a toddler, but maybe 5, 6, 7 years old. They don't like walking long distances with their family in the countryside at weekends, and everybody thinks they're just moaning and they're lazy. They get accused of being lazy, but they're not. Their legs are genuinely getting tired, and that is such an important thing to recognize and to show the child and to show the parents that their fingers bend back too far, their elbows do, their knees do. That's why their legs are tired. They're not making it up and they're not being lazy, and that helps the whole family. And it's just nice to be able to be in a position to defuse those tensions and help. And then in a practical way, the physiotherapy and the insoles helps a lot. Now, the thing about weak ankles, that can also mean that somebody is going over on their ankle and sustaining true sprains on a regular basis. Now, that's well recognized in adults. It's a very common area of work to do as a foot and ankle orthopedic surgeon, and I do a lot of that work. But what's less understood is that can happen to children too. Youngsters can twist their ankle, and the ligaments which are torn on the outside corner of the ankle don't always fully heal, even in youngsters. There might be a general feeling that, well, if you're young, of course, everything heals. It doesn't necessarily. This is something I realized fairly early on working in this field. And I realized that it's it's similar or directly comparable in some ways to the shoulder. Now, if you dislocate your shoulder, the chances of, and it's put back in by your specialist, by your emergency doctor, the chances of it dislocating again is very strongly linked to how old you are when it dislocates. Now, if I say that, most people will say, well, presumably the younger you are, the less likely it is to dislocate again. It's the other way around. The younger you are when your shoulder dislocates, the more likely you are to get a dislocation again at some later date, sometimes very easily, just by twisting your shoulder. And the older you are, the less likely it is to dislocate. Well, how do you explain that? Well, the reason is the ligaments of the shoulder, the front of the shoulder, and I appreciate I'm talking about the opposite end of the body from the one I specialize in, but ligaments in the front of the shoulder frequently don't heal very well. And the only reason the shoulder doesn't come out when you're older is because it becomes stiff. And when you're young, things don't become stiff even when you injure them. So if you're 16 and you dislocate your shoulder, the chances of it dislocating again are way over 95%. And I started realizing that although the ankle doesn't behave quite like that, children who sprain their ankle can also find that they then have a weak ankle which keeps spraining. So I sometimes need to do the same ligament repair in youngsters that I do in adults. And I have a feeling, I can't prove it, but I have a feeling that because of the way foot and ankle orthopedic surgery works, certainly in the UK, and that children's orthopedic surgeons tend to specialize in the whole children's skeleton, that diagnosis might not be recognized, and the surgeon looking after them might not be as comfortable as I am with repairing those ligaments in a child, because the technique's very similar with a few minor alterations. And the success rate is just as good as is in the adult, which is 90–95%. It's very unusual not to work. So ankle pain in youngsters, like in adults, can be due to problems in the foot. The way the foot is shaped and the way the foot works has a direct bearing on the way the ankle works, and of course, exactly the other way around. If anybody comes into the clinic and says, my ankle hurts, my next question is, I have to say to them, show me where it hurts, because I think I know where they mean by their ankle, but actually they might mean something completely different from what I think by the word ankle. So it's really, really important to see where that patient, adult or young person, points to when they say it hurts. Now, if it truly is the ankle, and they will then grasp around the ankle joint, the anatomical orthopedically named ankle joint, and there's a problem there, it is very important to look at the posture of the foot then, because if the arch is very deep, for example, or the arch is very flat, that puts a twist on the ankle and changes the mechanics of the ankle. And the solution to that might well be a custom-made orthotic insole which goes into the shoe to either support the arch or to actually tip the foot the other way if the arch is abnormally deep. And that is usually combined with physiotherapy, because while these symptoms have been developing, the muscles will tend to become stronger on one side of the leg than the other. There'll be an imbalance there. Quite often, in reaction to symptoms like that, the calf muscle becomes rather tight. And if the calf muscle is tight, the Achilles tendon is tight, and that puts a strain on the foot. So usually secondary problems have developed since these symptoms occurred, and it's important to be able to tease that apart and address those things as well. Therefore, it's quite unusual to refer somebody for biomechanical assessment by a podiatrist on a walkway and having imprints of the feet made without simultaneously referring to a podiatrist. And it's invaluable to have nearby a team of specialist colleagues where the podiatrists and the physios are working together under the same roof. That's very powerful, and it makes it much easier to address those problems successfully for the patient. So unexplained ankle pain, I guess I have to think, is that been unexplained until they've met me, or unexplained even after they've met me? Because it's unusual not to be able to explain something, but we can't always solve every problem for every person every time. Particularly in young people, unexplained ankle pain is something which one has to take very seriously, because it can be an indication of an amazingly broad range of underlying problems. That can range from a problem with the cartilage in the ankle to unhappiness at school or at home. And that's why, having had that, I'm fortunate in that I've had a very broad range of training at a high level. So I've worked in Toronto in a specialist trauma and joint reconstruction centre, where I did one fellowship and I did a second fellowship at Great Ormond Street Hospital in children's orthopaedics. And it's very useful to have that breadth of training and to be able to have those things in mind. So when as an orthopedic surgeon you're trying to help a young person with a problem, even if the symptoms are very physical, it's always important to be aware that you're not just treating the foot and you're not just treating the person, you're actually often treating the whole family, because parents are concerned about what might be underlying the problem, the symptoms, and could it be something really, really serious, either medically serious or serious from the point of view that this young person may be showing some real promise in high-level sports, and they want to do it and their parents want them to do it, and is this symptom an indication that they have a problem that's going to stop them being able to do it? So you have to approach it sensitively, you have to approach it with a very broad mind and make sure you exclude all the possible causes. Is it common? It's quite common in my clinics. I suspect it's quite common in the broader world out there of people who I don't see, because a physiotherapist successfully treats them, or a sports therapist. They manage to get referred to a podiatrist who can make some insoles. So there will undoubtedly be people out there who are successfully treated without needing to see me, but it is quite a common symptom in the clinics. That's quite right. Sometimes you can give advice over the phone and sometimes by video. And I'm certainly happy to, if necessary, especially if people have long journeys, to provide that sort of consultation. We can often get a lot of information that way. As I've been explaining in different parts of this discussion and this interview, an enormous amount of assessment is done by speaking to people and finding out what the symptoms are and how they're affecting them, and you can narrow the diagnoses down quite a lot that way. But it's really, in orthopedics is a very physical speciality as well, so it's always necessary to physically examine and to meet people face to face to really get to the bottom of it. But if somebody's asking me on a remote consultation, or I get some a request for written advice, the first thing would be to make sure that there hasn't been an injury, and that can sometimes be harder to find out than you might expect. Or has there been a repetitive thing, a change in sports, a change in intensity of sports, and maybe that's responsible. Unless there has been an injury which needs to be addressed quickly, most of the time it's safe to allow a little bit of time, find out, does their son or daughter feel they're being pushed too hard in their sports? Have they their sports team just been taken over by a well-meaning but over-enthusiastic coach, and that it's just too much? All those things should be checked for, and usually it's safe to give things a week or two. If it is an injury, treat it like any other injury with a little bit of rest and ice, and allow things some time to settle. So if orthopedic specialists were to see every person with a short period of symptoms, then there'd be a danger of over investigation, and it'd be harder for us to tell the people who really had a serious problem. So a short period of time is fine. If there's physical swelling to see, if there's limping which doesn't go away, they are more serious signs, and then I would advise at very least a telephone consultation, video consultation, and preferably a face-to-face assessment. And then it can be looked into in more detail. And if the end of that process it's still a question of reassurance and having excluded anything serious, that's fine. That's a big part of foot and ankle orthopedics, and all orthopedics come to that. So I think patients and even general practitioners sometimes are concerned that people should only come to see a surgeon if they need an operation. I'm not sure that was ever really true, and it certainly isn't true now. I was doing a teaching session for some general practitioners just 2 evenings ago, and we were talking about it then, and I did say that general practitioners should not be worried that I can't refer you to an orthopedic surgeon because before you know it they'll be doing an operation on you, because that's what they do. if those days ever did exist, they are long past, where keen diagnosticians were far more sensible than that. And we only ever suggest an operation for anybody, particularly in a youngster, but anybody, if there is a specific diagnosis which we know responds well to that operation, all other avenues have been pursued, and it's in the best interest of that person, all the risks and benefits weighed up, to have that operation. And I think the general practitioners realise that they're much happier to refer than they maybe were in the past.